All right, everyone, it is 12 o'clock, so we'll go ahead and get started. Welcome to Medical Grand Rounds at the University of Colorado. We have a very special Grand Rounds presentation today from several of our chief medical residents. Before we get into that and a brief introduction, I just want to remind everyone to claim your CME and MOC credit from Grand Rounds. You can do that with a link that Kelly will put in the chat. If you were to attend all of Medical Grand Rounds in an academic year, you'd get about 40 mock credits per year, which is more than you need in a time period. I will also remind everyone, if you have questions for our speakers today, please use the Q&A function within the Zoom. We are doing a semi-live event today, so we got a lot of residents in-house with us, but the chief medical residents will be monitoring the chat for questions that we will save for the end of the talk. And now I want to introduce our speakers today. We have three of our chief medical residents. I'll do brief introductions since there are three of them, and I know they have a lot to talk about today. But Manny Ura is originally from Pinar del Rio, Cuba. He then grew up in Miami, Florida, went to medical school at Creighton University in Nebraska. And Manny, fortunately, will be staying with us as a nephrology fellow this coming academic year. Sam King is originally from Leawood, Kansas. She did her undergraduate as well as her medical training at the University of Kansas. Apparently a school that has a basketball team, I'm told. She then came here for residency training, and we are lucky also to retain her as a pulmonary critical care fellow starting in the next academic year. And then Chris Caruso is originally from Keene, New Hampshire. He grew up in the East Coast. He did his medical training at Tufts University, came here obviously as a medical resident, and he will be going to the University of Pennsylvania for his pulmonary and critical care training in the year to come. I want to introduce our speakers as true experts on the topic today. This was the group of residents who were here as junior residents when the pandemic hit. They had to endure and go through and take care of a lot of the first patients that came through our hospital system, followed by 2 years of this pandemic, and now they are helping to lead others through it. So they truly are experts in this topic. The topic today is Hear Them, a recounting of residency training during the COVID-19 pandemic. Welcome to our chief medical residents.
All right, good afternoon, everybody. Welcome to Grand Rounds. I am Chris Caruso, one of the internal medicine chief residents. I'm joined today by my co-chiefs, Manny and Sam. And we looked back earlier this spring and we tried to decide what were we experts in that we could share with the internal. That while the pandemic may not be over, we're at a diastole moment. And this might be the right time for us to take a step back and look at what the last 2 years were like, specifically for our internal medicine residents. And that's how we kind of got to where we are today for what we're going to talk about for the next hour. We have no financial disclosures for today. Our one disclosure is that we are the internal medicine chief residents. And so we've chosen to talk only about residents for today, but we in no way mean to minimize what our nursing colleagues, our pulmonary critical care attendings, our pulmonary and critical care fellows, other staff, other attendings were during this pandemic, what they went through, what they suffered as well, and how it changed their careers and lives. These are our objectives today. As I kind of mentioned, we're going to go through what the pandemic was like in a chronological order with our residency program. We're going to do this by focusing on three residents. So as with any Grand Rounds, we're going to give you a case study on three residents and what they went through at different periods during the pandemic. Throughout the slideshow, you're going to see quotes on the screen like this one. Every quote in this presentation, except for two, are from our internal medicine residents reflecting on what the pandemic meant to them or from attendings within the program. This is the map or our guide for the next hour. This is the hospitalization rate in Colorado over the past 2 years. As I mentioned, as you notice right now, we are in that diastole moment in April of 2022. But we're going to start all the way back in the beginning. We're actually going to start before our first COVID case was diagnosed in March of 2020. We'll go through that initial surge, what it meant like to the program to move residents around, what it meant like for residents to be moved around. We'll then move into the deadliest time in the pandemic, which was that winter of 2020 into the spring of 2021. We'll fast forward a little bit and get to the Delta surge in the fall of this past year, and then what Omicron has done to us over the past several months. At the bottom of each slide, you will see this bar graph that's actually at the top of the screen here to guide you on where we are as we go through this presentation. So I get to introduce you to Jen. She's our first resident. She's an R2. She's a 29-year-old female. Her only real past medical history, she's got a lot of anxiety, really related to her medical debt from going to school for so long. She's going into the university ICU on March 2nd of 2020. It's the third week of her 4-week block. It's her first week of nights. She does what she usually does. She packs her dinner. She drives her car in. She parks in the garage. She takes the bridge you used to be able to take from the garage directly in the second floor of AIP2, takes the elevator up, finds her intern sitting at the dock box, and they go through the patients that are sickest that they both need to work together on that night. She then checks in with her attending, lets him know she's there, gets settled in for the night, and she gets her first admission. It's an 82-year-old man who's traveling from Delhi through Frankfurt and eventually to LA, but stops in DIA because of shortness of breath. He gets admitted to the University of Colorado on heated high flow nasal cannula due to acute hypoxic respiratory failure. This is his chest x-ray. This is March 2nd of 2020. This is 2 days before the first case of COVID is diagnosed in Colorado in Summit County. And it's multiple weeks before we'll see our first case of COVID at the University of Colorado Hospital. But Jen, that night, orders the first COVID test at the University of Colorado ICU. An internal medicine resident in their second year of residency ordered the first COVID test at our University Hospital ICU. Thousands and hundreds of thousands of tests will be ordered in the state of Colorado over the next 2 years. But this first one here came from one of our residents. Our residents have been here before we even had a case of COVID, thinking about, is this COVID? Is this not COVID? Do I order a test? Do I not order a test? And how long do I have to wait for that test to come back? And so that's Jen's first experience. Jen will leave the ICU after her block is over. She'll go to her endocrine outpatient elective that she has after that. But in the first week of that outpatient elective, her chief medical resident calls her. Her chief resident says to her, hey, Jen, I need you to come in and work in the surge ICU where we're moving all of the COVID patients or people we think that are COVID patients for. And we need residents to cover it. We're going to have a day resident and a night resident. And I need you to be that night resident. And so Jen goes from her endocrine elective that she was looking forward to learning more about endocrine as a career exploration. And she goes to what would be dubbed Surge 1. For those of you who don't know, at the University of Colorado Hospital, the COVID ICUs got labeled Surge 1 through X. And we got as high as Surge 5, with Surge 6 ready to open, but never needed to be open. Residents will remain, internal medicine residents will remain on Surge 1 from March of 2020 until it closed in January of 2022. Jen was the first one, but she was not the last over the next several months. So to give you an idea of what Surge 1 looked like at this time, as I mentioned, Jen was the first night resident and there was one day resident. And for the first several days, it was just those two residents in that unit. There was support from attendings in the ICU, but there was no dedicated intensivist. There was no dedicated fellow. Within that first week, we realized that wasn't really enough and we added another day resident, but still left one night resident to cover those patients. And about a week after that, there became a dedicated intensivist down there with residents as well. But initially, it was 2 residents and 16 patients in Surge 1, which is located in the critical care annex in AIP 1. For the duration of that academic year, we took residents from their elective and clinic blocks and moved them into the surge units to cover these patients. However, by June of 2020, we realized that we were taking a lot of elective days away from residents, and we'll quantify that for you in a moment. And so we had to restructure the way we staff these units, but we continued to staff them. And so for June of 2020 into the next academic year, instead of taking residents from outpatient electives, we took them from inpatient electives. And so third year residents were pulled as a senior resident, primarily from neurology, bone marrow transplant, and our oncology services that we staff, and moved into Surge 1. We took interns also from inpatient electives and moved into Surge 1. At this time, the hospital also added a dedicated pulmonary and critical care fellow, but there remained one night resident overnight with the help from the intensivist that was located in the MICU. And so we upstaffed to 5 members for a lower number of patients, realizing that 16 was probably too many. And this is what we did for the next academic year. But then, this past summer in 2021, we were lucky enough that we had a decrease in the number of COVID patients, such that Surge 1 closed for a brief period of time, and the COVID patients instead went directly to the MICU where they were cared for by our residents. But then with Omicron, we had a reopening of Surge 1 actually before December 1st of 2021. But we as a program realized that we couldn't continue to put our residents in the unit and take away educational experience. And so we moved with the University of Colorado Hospital into a Moonlighter model. But there was still an internal medicine resident on that service every day until it closed until January, just through a different method. As you'll notice, we increased the number of staff members over an extended period of time. For a very short period, we surged, and we realized that that wasn't sustainable over a long term. We had to add faculty, we had to add staff, we had to have support for our residents, for our fellows, and for our attendings in these units. So we're going to talk about this effect it had on the residents and their schedules and their education at the beginning of the pandemic. To do that, we have to back up for a second and talk about residency education and in the first place. 3 years ago, the University of Colorado Internal Medicine Residency Program moved to what's called a 4+4, which essentially means every month that you have an inpatient, the next month is an outpatient. For Jen, she went from the university ICU to her endocrine outpatient elective and then went to the CICU after that. And so that's how residence schedules have been done for several years now. This is what the elective schedule looked like in April of 2020. This slide is meant to show you two things. The first is it's meant to be an incredible credit to our staff of the internal medicine residency program, who we could not have done any of this without, as well as the chief residents at this time who had to make all this happen. The second piece is, if you'll notice here, if you look closely, every red block is a day a resident was taken off of their elective and put in either a COVID ICU or to cover for a resident who was out getting tested, out sick, or couldn't be in a unit because of concerns for being immunocompromised. This month of April, every resident who was on an elective was pulled to cover for COVID. What effect did this have? So in the first 4 months of the pandemic, residents lost almost 1,000 elective days. They lost 150 clinic days. And those aren't days that got moved to telehealth or canceled because there are no patients. Those are days residents lost seeing their patients in continuity clinic because they were pulled into coverage. At the same time, we had to cancel 45 elective rotations for numerous reasons, and 150 residents had their schedules impacted. To put that into perspective, there's about 170 residents in this program. And so suffice it to say, the vast majority of residents had their schedules impacted in the first 4 months of the pandemic. Gia, can I have you read this for me?
When the pandemic started, I was still trying to figure out if I wanted to pursue fellowship and wasn't sure which one. My electives got canceled and the structure of our wards dramatically changed. I had to push my elective to my second year and then felt rushed to make a decision on whether to pursue fellowship or not. It was also hard to find research projects at the time because a lot of research was put on pause due to the pandemic. I do wonder if my career choices would have changed if there wasn't a global pandemic during my residency training.
This is the sentiment of just one of our residents during the beginning of the pandemic and how they felt having this educational time, having this alternative time for career exploration to be taken away. Our residency program did the best they could in the beginning of the pandemic to protect residents from seeing COVID patients so as not to lose those educational opportunities on other services. In March of 2020, the only places residents saw COVID in the inpatient setting were places where there were no other non-teaching services. So that's the Surge ICU, our Denver Health ICU, the VA, which has no non-teaching services, and university wards on swing and night coverage. By January of 2022, every inpatient rotation we have as a program will have had a COVID patient on that service whose primary diagnosis was respiratory failure. That is to say, there was no inpatient rotation for 2 years a resident could go and not see a COVID patient. Jen went into the surge unit that first day in March of 2020, and I don't think she or any of the residents that have been in this program for the past 2 years had any idea what it would mean. But here's some of the 30,000-foot numbers of our institutions we see as a residency program over the past 2 years. The University of Colorado saw over 7,000 COVID patients admitted, with over 800 of those in the ICU and over 600 dying here at the University of Colorado Hospital. There are about 14,000 ICU days due to COVID patients. Over 5,000 of those were due to Surge 1 patients alone, which again was staffed entirely by internal medicine residents. At Denver Health, they saw almost 4,000 COVID cases, with over 706 in the ICU and 119 ICU deaths. And our internal medicine residents were there for every one of them. At the VA, there were over 700 cases. And as I mentioned, there are no non-teaching services at the VA. And so every veteran admitted with COVID for 2 years was cared for by our internal medicine residents. To personify this a little bit, this is Robbie Thurman. She was the first patient at the University of Colorado Hospital who was intubated for COVID, successfully extubated and discharged. You may not know it from reading this article, but she was admitted in the middle of the night by an internal medicine resident and a pulmonary and critical care fellow. During her hospitalization, over 16 residents will be involved in her day-to-day care. Oftentimes, the work of residents went unrecognized by our local community. To top this all off, everybody listening online, everybody here in this room, not everybody may have been a resident, but everybody's been a trainee. This is an incredibly vulnerable period in your career and your life for a number of reasons. And so one of the hardest parts for our residents is the fact they went back and forth between inpatient and outpatient. And so data changed, information changed, the world around them changed on a weekly basis as it did for all of us at that time. but it was magnified for our residents because of the switching back and forth. In the beginning of the pandemic, we didn't know if you could keep your patients on ACE inhibitors or give them NSAIDs when they got admitted. You weren't sure if you saw them in clinic, if you should stop them and what you should do with them if they got COVID. Then you would go to your inpatient month and we'd be having discussions around, should we be giving COVID patients CPR? Is it ethical to say, no, we're not going to resuscitate you if you code? How much of an educational benefit do you lose out if you're the resident and you can't be in the room because the patient has COVID and they code? But is it safer to have you out of that room? At the same time, on every COVID patient's door was this sign. And this affected no one more than our nursing colleagues, but this affected residents too. In the beginning, someone had to watch you don all of your PPE, and someone had to watch you doff all of your PPE. And the whole time you wondered, am I doing this correctly? Did I wash my hands the right number of times? Did I take my visor off appropriately? Did me putting my mask in a paper bag and then taking it back out put me at risk for getting COVID? You would leave and then come back, and things you were doing a month ago were now not right. Initially, we gave everybody hydroxychloroquine and azithromycin, and within a 4-week span, it disappeared in academic settings. And our residents had to catch up to that continually. At the same time, there were very personal connections we had going on in the world. We had 2 of our colleagues die across the world, one very close to us, the bottom here being an OBGYN resident in Dallas who died in June of 2020 from COVID. And so it magnified that question of, am I safe going into this room, as it did for so many of us who were not residents. And as I may not have mentioned earlier, Jen was a transplant. Jen was from Providence, Rhode Island. She came out here for residency by herself, bringing only her dog. Most of our residents, the majority of our residents, are transplants here to Denver. So they don't come with family. Most of them don't come with friends. They're residency, other friends. And so if you can't socialize with your residency and you're worried about if you're safe to go home and see your family, it provides a lot of social isolation that Manny will get into a little bit later.
During 1 week as a second year in the UCH MICU, we helped offload patients from the COVID ICU. By the end of the day, I knew all those patients so well. Their names, their loved ones' names, what they liked to do for fun, what they valued, who they were as people. And for the next week, I called the coroner at least once every day. None of those COVID patients survived.
I remember my first code in the CCA in March of 2020. We were the night team standing outside the door watching the patient's arterial line as his blood pressure dropped to an undetectable range. 2 nurses rushed to open the door to start compressions. I had to tell them to stop so that they put PPE on before entering the room. All our instincts were to rush into that room. Telling yourself you must protect yourself before your patient is hard. The 30 seconds it took to put PPE on felt like a lifetime. In that moment, I felt so helpless to save that patient.
One night early in COVID, a delirious patient kicked off a nurse's respirator. She came out of the room crying. The charge nurse sent her home from the rest of her shift. No one had any idea what to say to her. I was so fearful that she had just gotten COVID, but did not know the right thing to say to comfort her.
So my job now is to introduce you all to Adam. Adam's a 29-year-old male. He's actually going to be Jen's intern in the Denver Health Medical ICU in November of 2020. A little background on Adam. He's originally from New York City, but he made his way to the University of Colorado for its strong primary care track, which he's now a part of. And you guys can remember this. Right before your first ICU month as an intern, you're nervous. And so he's reading about sepsis management, reviewing landmark ARDS trials, even looking into sedation strategies in the ICU. But at the same time, he's hearing about rising COVID cases in Colorado, and he wonders what effect that's going to have on his rotation. As you all can imagine, there's no amount of studying that you can do to prepare yourself to have your first critical care experience be during a global pandemic from a respiratory pathogen.
I'm not immunosuppressed or pregnant or chronically ill or elderly. In the absence of these conditions, does my profession now demand that I embark on an expedited journey of self-discovery that ends with a fearless proclamation of my unwavering sense of duty? Because I don't think I have that. I'm pretty sure I don't. When I look within, I don't find the bravery and confidence that I wish were there.
So we just shared with you all a quote from an internal medicine resident that was published in the New England Journal of Medicine. And sentiments like this were felt amongst trainees all over the country, from fear of getting sick yourself to transmitting the virus to one of your loved ones, to uncertainty about what this meant for your career trajectory, to even guilt for not reflexively wanting to be a part of the initial COVID response. But despite all those feelings, our residents did step up and they provided care for our patients. So what we'd like to do now is to quantify Adam's experience and residents like Adam's experience over these past 2 years. So during his month in the Denver Health Medical ICU, a total of 174 patients will be admitted. There will be, on average, 1 death every single day for the entire month, leading to an astounding mortality rate of 17%, which is much higher than the average in that unit. Adam himself will pronounce dead 12 patients over the 4-week block. The rise in acuity and mortality that was sensed in ICUs across Denver correlated with the surges of COVID cases. And what we'll do now is we're actually going to step back and look at the totality of these 2 years, specifically at Denver Health. And we'll note that there were a total of 3,970 COVID admissions. Of those, roughly 18% required ICU admission. Those patients that were admitted to the ICU, roughly half required mechanical ventilation. And out of all COVID ICU patients at Denver Health, nearly 17% would die. If we take a close look at the year 2020, we see almost a doubling of the mortality rate within that unit, up to 11.7% from a baseline of 5 to 6 in years prior. And these numbers are sobering and staggering to look at, but I think this is a good time for us to actually take a step back and ask the question, who were we caring for during this troubling time? And before we look at Denver data, let's analyze what happened nationally. If we specifically look at this 50 to 64-year age group, we note that Hispanic individuals comprise roughly 13% of this demographic, yet they accounted for 25% of all COVID deaths. When we look at Black individuals in this demographic, they account for roughly 11%, yet they accounted for nearly 20% of all COVID deaths. And we have to contrast that with our white individuals in this demographic. They represent almost 70% of this demographic, yet only account for 50% of all COVID deaths. So another way to think about this, if you're Hispanic or Black during the pandemic, you were at least 2.3 times more likely to be hospitalized with COVID-19. If you were Hispanic or Black, you were at least 1.7 times more likely to die from COVID-19. So were we spared from these health disparities here in Denver? The unfortunate answer is no. And when we look at all the patients in the Denver Health Medical ICU that died, we found that 70% of them were either Hispanic or Black. And to provide a little context, in our Denver community, our Hispanic individuals only comprised 25%. So this was a staggering realization, but I think it comes to no surprise to any of us who cared for these patients during this time. We also want to point out that greater than a third of all patients at Denver Health in that ICU with a COVID diagnosis did not speak English as a first language. They spoke Spanish. And so COVID really magnified a lot of the health disparities faced by our country. And there's a series of factors that play into this. They're all depicted here in this infographic. But I actually want to choose to spend some time on one that's not explicitly stated here, and that's occupation. So you all may not know this, but 40% of all frontline workers are either Hispanic or Black. And there's countless anecdotes from our trainees where patients told them things along the lines of, I wish I had the option to work virtually, but I don't. And my family needs me to work, so I continue to work. Or, I wish I didn't have to, but if I don't work, who's going to pay the bills? We even heard some patients say, I had symptoms, but I continued to work because my family counts on me. And to add insult to injury, many of these frontline jobs are low paying and don't even offer insurance benefits. And so what was the sum total of these unfortunate circumstances? There's a lot of pain and suffering for our communities of color. So what was it like to actually be in a unit caring for these patients? We'll come back to Adam. Adam shares with us he's frustrated. He's frustrated that he can't convey empathy over the phone when using a translator. He's upset that he'll never meet the loved ones of his patients or offer them a warm embrace when he delivers difficult news. But what weighs heaviest on Adam is how alone his patients are. Instead of having a family member at the bedside, our amazing nursing colleagues are the ones who take on this role, hold their hands, or offer a prayer during moments of difficulty. When the COVID-19 pandemic began, there was a federal and state level recommendation to implement restriction on visitation throughout all the hospitals. And those restrictions were implemented. And we reached out to hospital leadership and inquired about this. And they mentioned to us that at that time, that was the decision to make, but they do understand that it came at a cost. And I think as trainees, we can accept the fact that these policies were implemented, but I think we must also recognize that this contributed greatly to the moral injury and distress faced by our nurses, our faculty, and our trainees.
Up until COVID, I haven't felt such Up until COVID, I hadn't felt such a
I'll help us out with this one, Emily, while we work through the microphone. Up until COVID, I hadn't felt such a degree of pervasive helplessness. We just didn't know what to do to help these patients, and it seemed like even the patients that should have done well didn't. And we couldn't offer them anything, not even a family member's presence or comfort.
I felt defeated asking a family to choose which two people out of a wife and 3 children could be in the room with the patient when we removed the breathing tube. I will never forget the screams of that patient's wife.
And so we can look to some data that actually looked into this a little bit. This was a large cross-sectional study out of 21 French ICUs. What they were trying to do was identify which consistent factors contributed to poor mental health outcomes in providers in COVID care units. And among those factors, regret about the restrictions and visitation policies actually ranked among the highest. If we take a step back and think, what was the effect for our trainees specifically in caring for these patients? We can look at this very large international survey that had good United States representation that essentially shows a proportional increase in feelings of burnout and callousness, depending on how many COVID patients you cared for as a trainee. So for example, if a trainee cared for over 30 COVID patients over a 2-month span, they would screen positive for burnout at a rate of about 65%. And those same trainees would endorse feelings of callousness at a rate of 44%. And so initially, it was an all hands on deck approach to make sure that we mobilized internal medicine residents and we took care of these patients. But I think program leadership recognized that we had to also protect our residents and maintain their well-being to a degree. And so our program leadership ensured that our trainees had time away from COVID care, and the 4+4 schedule allowed the opportunity to oscillate between the inpatient setting where you'd care for these patients and the outpatient setting or elective setting. As Chris mentioned, a lot of our trainees were pulled from their elective setting, but they were always guaranteed time off to recover after providing COVID care. And when we asked our trainees, what were other factors that contributed to your well-being and made you feel supported during this time? They brought up these regular virtual town hall meetings led by our program director, Jeff Connors. Not the most flattering picture, but I apologize. And this was an opportunity for our trainees to be able to share some of these difficult experiences that they were having. It's an opportunity for program leadership to contingency plan for the upcoming surge. But most of all, it created a direct line of communication between our trainees and program leadership, and that went a long way. We also were lucky enough to have dedicated faculty, like Dr. Kelly Ferraro, one of our palliative doctors, who would just come to the Denver Health MICU workroom and sit and allow residents to vent through these difficult and possible emotions. And that meant a lot to them as well. So on behalf of the residents, we really want to extend a big thank you to program leadership and to our dedicated faculty. So we come back to Adam, and Adam's getting near the end of his Denver Health MICU month. And after a busy month, most residents plan to get together with some friends, grab a beer at a bar, catch a baseball game. But this won't be happening for Adam. COVID cases are still rising, and Adam's not going to choose to get together in any large setting. And if I'm going to be honest with you, Adam hasn't really made any friends so far in residency. He never had an in-person intern event. He never made it to any welcome get-togethers. He's never even been to an in-person educational session. There are social cohorts, but he's never met them. And this year, the R3s will graduate from behind a computer screen.
COVID made me pause when hanging out with large groups of people, unfortunately, which made it difficult to socialize within residency.
So much of residency is about community and friendship and doing something hard together. COVID gave us the hard, but it centered it together, and it truly is half the experience.
So we're actually going to pick back up with Adam now in August of 2021. And for many of you in this room, this is still fresh in your mind. This is a big month for Adam. He is no longer the intern. He's about to be the junior resident on the University MICU team. This is a big month. He's excited to take a little more ownership of the team, be granted more autonomy, and teach his intern. At the same time, though, he's nervous. Maybe he doesn't have the skills quite yet to be an R2. All at the same time, he's hearing about these record-breaking COVID cases due to the new Delta variant. And he wonders if this month is going to be eerily similar to his last ICU experience.
On my first day as a PGY2, I was covering the day shift in the MICU. One of the new interns came up to me and told me that our patient had been more agitated overnight. Could we bolus him with some more propofol, the intern wondered, or maybe fentanyl, or maybe we should try Precedex, or maybe the patient was agitated because something else was going on and sedating would mask a potentially lethal underlying pathology. It was here that I felt truly paralyzed for the first time. I instinctively looked over my shoulder for my senior resident and realized none was present. The decision was mine.
So many regard this transition from intern to junior resident among the hardest in all of medical training. Feelings of anxiety and imposter syndrome are at an all-time high. I think all of you in the room and those of you listening on Zoom, you can recall to this point in your career and remember just how vulnerable you felt. And that was during normal times. Adam isn't going through this transition during normal times.
One lesson I learned is the importance of family in medical decision making. Often for very ill patients with COVID, we only interact with their family members. I think we dealt with a high proportion of family meetings, end-of-life discussions, code decisions, etc., which helped me develop skills necessary to have empathetic, meaningful conversations with family about the care of their loved ones at the end of life.
So in addition to these difficult transitions in medical training, our very junior residents also had to navigate complex, nuanced discussions around vaccination hesitancy or COVID treatment preferences. They had to make sure that they were staying up to date with the evolving data around COVID, and they had to know what the latest recommendations for treatment of COVID patients were. But more important than that, they had to develop communication skills at lightning speed, because this cohort of residents would engage in more difficult conversations and end-of-life conversations than any cohort before them. And this was actually noticed by several of our MICU attendings.
I now regularly have interns talking correctly on rounds about driving pressures and the vent changes they wish to make.
There was significantly improved understanding of the basic pathogenesis and mechanisms of common critical illness, high levels of proficiency in managing death and dying in chronic critical illness.
All right, guys, so I'm gonna bring this back to Adam. I wanna remind you of something really quick. Adam doesn't really have big interest in critical care. Adam's a primary care doctor in the making, right? But despite that, Adam feels fortunate that through residency, he gained the skills to be able to care for critically ill patients during the pandemic. But Adam does lament the fact that he doesn't feel a sense of community within his residency, and he hopes that that changes soon.
I also think, good or bad, everyone recognizes that this was a defining moment in their careers. It marked time in a major way, and I think this is as good as we reflect on and define our lives.
So Chris and Manny have illustrated what it looked like to be a resident during the last 2 years. But what did it look like to apply for and enter residency training during a global pandemic? And so I'd like to introduce you to Izzy, our third and final resident for today. She's a 33-year-old female. She's an intern in our categorical track. She's originally from Wisconsin, and she moved here this past summer with her husband and their 3-year-old daughter. But back when the pandemic began, Izzy was in her 3rd year of medical school. And one day in the middle of March of 2020, per the advice of the American Association of Medical Colleges, Izzy was abruptly removed from her obstetrics and gynecology rotation. This was a time where usually she'd be seeing patients in clinic, on the labor and delivery service, or in the operating room. And after that, she would go on to complete her pediatrics and surgery clerkships virtually as well. Our current interns report that on average, they had 3 of their clerkships disrupted, either canceled, converted to a virtual format, or otherwise modified because of the COVID-19 pandemic. And for reference, at most medical schools, 3 clerkships represents anywhere from 1/3 to 1/2 of the core clinical training during the 3rd year. And as we know, the pandemic continued into Izzy's 4th year, and she prepared to apply to residency. Izzy decided to apply to residency in internal medicine. It's been her favorite clerkship thus far. Thankfully, she got to complete it in the fall of 2019 before the pandemic hit. But as she fills out her ARIS application and is writing about why she wants to be an internal medicine doctor, she can't help but wonder if she's making the right decision. After all, she never participated in a well child visit on pediatrics, and she never actually stepped foot in the operating room during her surgery clerkship. And while she's preparing to be in the first class of students to interview virtually for residency, applicants are applying to more and more programs. This is a graph of the average number of applications submitted per applicant to internal medicine residency and fellowship programs over the last 6 application cycles. And as you can see, applicants have applied to more and more programs every single year. Internal medicine is represented by the dark circles, the 3rd line down. The other lines are fellowship programs within internal medicine. And though applicants have applied to more and more programs every year, the jump is most pronounced during Izzy's cycle. And while Izzy applies, each applicant is applying to almost 72 internal medicine residency programs. And she wonders, in this sea of applications, how am I going to stand out, especially from behind a computer screen? And on top of that, she's wondering, how will I know where to go? Because the most consistent advice she's gotten is trust your gut. You're going to know if a program is right for you based on the feel when you visit.
I think the only thing I was worried about was how accurate my vibe was of the program from the Zoom interview.
And so after 21 Zoom interviews, Izzy's anxiously awaiting match day. But as her 4th year continues, she can't help but notice the effects that the pandemic is having on those around her.
It felt hard to sit on the sidelines as a 4th year medical student, watching so many residents and attendings be overworked and tired when I wasn't going to be getting any more training before being asked to do the same work.
But then in March of 2021, Izzy matches at her first choice for internal medicine residency here at the University of Colorado. And in June, she moves here. And this is actually the first time that anyone in Izzy's family has stepped foot in the state of Colorado. But relatively speaking, it's a good time to be moving to Denver. In June of 2021, case rates are low. Nearly all of our residents have received 2 doses of the COVID-19 vaccine. And over half of Coloradans are vaccinated. And thanks to this, unlike the class before her, unlike Adam's class, Izzy gets to participate in some of our traditional social events. She gets to go to the welcome barbecue and meet the entire program at Washington Park. And after a long day of in-person intern orientation, she gets to meet up on a patio in Rhino with some of her new co-residents. But as Izzy is meeting her new co-interns, they do share this sense of anticipatory anxiety.
I hadn't physically been in a hospital in 9 months when I started residency, so I felt like both my practical knowledge about navigating care and medical knowledge were less than what I had hoped.
I was worried I was more out of practice than the traditional intern, and I think imposter syndrome was amplified.
Over half of our current interns report that they perceive themselves as less prepared for residency than the traditional intern because of the COVID-19 pandemic. But thankfully, Izzy's residency is off to a good start. In July, she enjoys a month of primary care medicine at her continuity clinic. And in August, she's preparing for her first inpatient month at the VA. She's a little bit nervous. She's never worked at a VA before, and our VA operates an open ICU model. And so in addition to caring for patients on the general medicine service, she'll be taking care of patients in the intensive care unit. And just like Adam, she's watching case counts rise as the Delta variant hits Colorado. And she wonders, how many of the veterans that I care for this month are going to be critically ill from COVID-19? And unfortunately, the answer is quite a few. And in the first week of Izzy's rotation, she takes care of a patient named John. John's 38 years old, just a few years older than her. He came to the emergency department with shortness of breath, and he's rapidly intubated for acute hypoxic respiratory failure from COVID-19 pneumonia. And even though Izzy is admitting John, she's the primary doctor in charge of John's care, she can't talk to him. And because of visitor restrictions, his family's not there. John's alone. So Izzy calls John's family. She wants to update them on what has happened and convey how worried she is about John. His family is understandably upset, and they share with Izzy that John is not vaccinated. and they plead with her to please look for another cause of his respiratory failure. This can't be COVID because COVID does not make you this sick. And Izzy feels defeated. She has to wonder, would John even be in the hospital at all if he had received the vaccine? She thinks back to the day that she got her first dose and how much hope that she had. How could John not have wanted that? Maybe we're never going to get out of this. And why doesn't John's family trust me? There aren't yet any published data about the effects of vaccine hesitancy on our healthcare workers or trainees. But when we asked our residents to identify one thing that they've learned from being a trainee during the last 2 years, many of them highlighted this experience of caring for those with deep mistrust of our healthcare system.
Everybody comes to vaccination with a different mindset, informed by the people they trust and the things they see. But at the end of the day, they are all equally scared to have gotten COVID and equally deserving of care.
COVID taught me how to care for patients with empathy and dignity, even if I disagree with their decisions or beliefs. But it also taught me to stand up for myself, my teammates, and my patients and community. I've been harassed and threatened by patients who didn't believe in COVID. I have also seen the devastating impact it has had on many patients, especially my Latino and Black patients. People's decisions affect others, and COVID has been a lesson in having difficult conversations and learning when I need to protect my own well-being.
Often I felt that leadership wanted us to be totally accepting of patients with unvaccinated status, and we tried, but this is unrealistic. I could not truly cope until I accepted my personal frustrations, spoke about it, and developed strategies to get past this feeling and to continue to provide the highest level of patient care. Pretending that the feeling was not there or being ashamed of it was not helpful. ICU attendings, fellows, and nurses were all helpful in coping with this.
It's possible to acknowledge anger and frustration, even at a patient's choices, and still do the utmost to provide them the best care we can. I think sometimes in medicine, we're asked to ignore and shove our personal feelings away for the sake of patient care, with the idea that one should always be understanding and non-judgmental. I think COVID has really tested that idea, and I would argue that while there is a lot of anger and frustration, it has been possible to talk about it and acknowledge those feelings in the open without compromising patient care.
And that month at the VA, it was hard for Izzy. And stories like John's, unfortunately, became all too familiar. But one thing she was thankful for that month was the camaraderie she felt not only with her co-residents, but also the nurses at the VA. Several of our residents commented on how this pandemic has changed the culture of our hospitals, in particular our relationship with the nursing staff, without whom we quite literally could not do our jobs.
We struggled together coping with why patients were unvaccinated or so mistrustful of the work we were doing throughout. Each hard case was one we would talk about together and all struggle with, but each success was also one we celebrated together.
I think COVID brought us closer to nursing and faculty around a shared common enemy.
There's a sense of shared experience and suffering, an acknowledgement that neither of us are treated with the respect or compensation we deserve. There have also been times where we are also burnt out, that we struggle to support each other in the way we want to.
So I'd like to catch back up with what our 3 residents are doing now. Izzy's currently on a rheumatology elective, and last Friday, she got to go to the program's Spring Fling event. The program planned its first in-person holiday party in 2 years, but Omicron had other plans for us, and we had a spring party instead. And regardless, Izzy's thankful to be making some friends outside of the hospital, but she still feels uncertain about what she wants to do in terms of her career.
I feel more unsafe about my career path because most of my subspecialty rotations were canceled in medical school due to COVID. So the first time I'm trying a lot of specialties has been during my intern year.
And Adam, he just got back from Orlando from presenting at the Society of General Internal Medicine Conference. This is the first time in over 2 years that our trainees have presented in person at a national conference. He's a second year now. He's starting to think about applying for primary care jobs. And in doing so, he's considering how the pandemic has changed what's most important to him.
My priorities have changed. I value my free time and quality of life so much more now, and I find that I am less career driven. While I love being a doctor, it's also exhausting, and I can't pour the same time and emotion into it that I used to and still be a well person.
And Jen, she graduated last year, and she's completing her first year of gastroenterology fellowship at the University of Washington. But when she thinks back on her time at Colorado, the pandemic is at the forefront of her mind. And she can't help but wonder, am I a better GI fellow because of that extra critical care time? I think it made me better at making quick decisions, and I'm definitely comfortable managing GI emergencies. But at the same time, she wonders, did I miss out on some of the fundamental experiences that I needed as a trainee to be a well-rounded physician? Maybe I'm actually a worse GI doctor because of this. And I think it's too early to say what the long-term effects of this pandemic are going to be on our developing physicians. But without a doubt, this is a time that we will all look back on for the rest of our lives.
I was working in the MICU at DH March 2020. It felt momentous to be taking care of patients with a disease that no one had seen before, and we did not yet understand or have much guidance on how to treat. While sobering, I also knew it was a unique experience I would look back on throughout my career.
And I would like to end with this quote from one of our faculty in program leadership, who says, "The training program and the hospital systems are lucky to have such an amazing group of residents who have shown such resilience and commitment to their patients and communities during such difficult times. Our major health systems, and by extension our patients, would have quite literally been sunk without them." And so to all of our residents, thank you. We'd also like to thank everyone who helped us compile data for this presentation. And as we've mentioned before, there are innumerable people who have supported our residents over the last 2 years. It feels impossible to list them all, but to everyone listed here and then some, thank you. And with that, we would love to take any questions.
Thank you all. That was fantastic. It's rare to get such emotion and transparency in a Grand Rounds talk. I think that was incredibly brave. So thank you for that presentation. I'll take questions from our audience since we actually are here live for the first time in a while. So I'll wait for hands to pop up. That one over here. Dr. Canese.
I have no idea if you'll be able to answer this in some of the research you guys came across, but having been through this with you all, I think our program did a really good job of protecting us, but the programs did not, and residents were in a uniquely unprotected space where they can't switch careers, they can't leave, they've got massive medical debt, they are frequently on the front lines, and in some cases even being asked to do things the attendings weren't. Did you see anything about like ACGME trying to protect residents more, or different like rules being implemented so that if this happens again, it's not residents that will be taken advantage of? And again, I think our program did great, so.
So we didn't look specifically into what the ACGME asked for. And so it's hard to say exactly what other programs did, right? I think everybody in this room is aware that we were probably not the most hardly impacted area in the country, that New York initially with the number of residents that were impacted there. There's actually a good number of literature about the number of residents in New York who got sick in the initial wave, which was like upwards of 50% of their programs at that time. And so whether that's because we were protected or because our rates of COVID were different than theirs is hard to know. It is interesting to look, we looked at the comparisons of hospitals of peer institutions across the country and the variability in the number of cases that were at each institution. And so as I mentioned, New York had a significant number or significantly higher more cases than we did at their academic institutions, whereas San Fran actually had significantly lower COVID admissions than we did here. And so I don't know if there's any particular thing the ACGME did to protect us necessarily. I think it was more based on where we were in the country in a lot of ways, or what our program individually did.
Right. As you acknowledged, there was some sentiment in the greater medical community during the pandemic that this, quote, wasn't what we signed up for. Knowing now that something like COVID can happen, how would you advise aspiring physicians about what they are, quote, signing up for?
I think in a lot of ways, this profession boils down to service of others. And so regardless of the disease process or the patient population that's being affected, I think the biggest question to ask yourself as a trainee is the biggest motivation behind you wanting to become a doctor to be in service of others? If the answer is yes, then I think you can handle any pandemic that were to come your way in the future. So that would be my answer to that probably.
Thanks, guys. That was an amazing talk. Having kind of relived that experience for the past 2 years, do you guys have any suggestions or guidance for, what happens with the next surge and things that we can do to better protect our residents?
I can't. I'll answer that one. I did the initial surge. It makes the most sense there. So it's hard to say, right? In the beginning, we realized what we did was probably wrong. I think mostly because we had no idea what we were doing in so many ways, right? And you didn't know how long it was going to last. And so it was put as much effort as you could into what you thought would be a short period of time. And then obviously it lasted longer than 2 years. And I think the hope is if we do see another surge that it won't be that long, hopefully. I think the things that helped residents the most that we saw on a regular basis was open communication. I think was probably one of the most important things residents felt during that time period, whether that was because of the town halls we did or regular emails or regular check-ins from the chiefs or APDs, whoever it was. That felt like that way. How do you build a community so I know what's going on? And then the other piece of how do we not disrupt everyday education? Whether that's in-person education with our Wednesday educational sessions, or whether that's you getting to do your elective as an outpatient, and that keeping that area safe from, in this case, COVID, is probably one of the most important things we can do to help residents still feel like they're a part of a residency program rather than just working until the COVID cases stop.
Then we have a question from Dr. Rick Albert. Do you think that COVID has had any effect on the decisions to pursue academic medicine versus private practice?
That's a great question. And I don't know the answer, but I think we were all surprised in looking for data on the effects of the pandemic on our trainees that almost no data exists yet. There are some descriptive studies of what medical schools and programs did to adapt to the pandemic, and some very small studies from medical schools about the effect this had on medical student education, but there aren't national level data on the effect on career trajectory or that topic.
The question while we wait for other questions from the audience, what's your 10 and 20 year concerns? These things had an obvious immediate impact, many of them negative. There's some positives as you highlighted in your talk. But I think, something will come of this in 10 or 20 years. Based on your research, your study, what you've looked at so far, what are your guesses or what are your concerns?
I'm sure my co-chiefs will add to this, but I think one thing that we noticed in talking with our trainees is there's started to be a little bit more of a shift towards preserving your own well-being. The incidence of burnout was so high during this pandemic and during all this time of uncertainty. And I think trainees are starting to prioritize their well-being and their life outside of medicine a bit more. And I wonder if in the next 10, 20 years, folks take a little bit, their foot off the gas a little bit in terms of career aspirations and maybe focus on caring for themselves and their family a little more.
Yeah, I think the only thing I would add to that, I think ARDS treatment in the community will have changed for the foreseeable future, right? I think until this group of physicians leaves, is the way we treat respiratory failure in the community, I think will have changed for a significant amount of time, which is interesting when you think about it. I saw 2 cases of ARDS in residency before COVID. And how quickly did people see 2 cases of ARDS in residency when they started in the last 2 years, right? That's an incredible change that we've seen. And so you think about the impact of that on a bigger level is interesting, is that it will, as our residents go off into non-academic positions, that we'll see care change across the country, I think.
Given COVID was a novel disease with novel and emerging therapies, in what ways do you think residents were uniquely advantaged, and what ways do you think they were uniquely disadvantaged being on the front line of patient care compared to more experienced colleagues?
I think that Chris touched on how hard it was as a trainee to be going back and forth between different clinical settings. You are in the hospital in the ICU for a month taking care of COVID patients. You're hearing about COVID updates every single day. And then maybe you go to an endocrinology elective and COVID's not at the forefront of your mind. And you come back in 28 days and you feel like everything has changed. And so I think the inconsistency of our practice setting over 3 years made things harder. But we were also advantaged to be at an academic medical center where people brought us back up to speed. It felt like when we came back from doing non-COVID care.
Yeah, and I would add to that too, that our residents were one of the few provider groups that saw COVID across the entire spectrum. So from the outpatient setting to the wards to the ICU to what recovery looked like. And so I think in that regard, we had some advantage in terms of kind of understanding the disease process throughout all of its phases.
And I think the last piece of that, I mean, we talked a little bit about how COVID patients ended up on non-COVID units. And in most of those units, the attending provider or the fellow for that matter hadn't cared for COVID patients. And so it was almost like the resident became the expert in COVID on that unit, which is fascinating when you think about it, but was the reality of how we really helped out the institution when they had to flex to put COVID patients on other services.
Dr. Shah.
I think one of the other effects we saw in the pandemic was obviously the effect on nursing, people leaving their jobs as nursing or taking traveler jobs that pay better. And I was just curious, as a resident, having interactions with kind of the new traveler nurses, is there kind of like a plan to bring them a little bit more up to speed on the university or the Denver health systems? And just kind of thinking about ways to build rapport between the travelers and the residents as well.
It's a good question about like training and traveling nurses. Several residents commented on how they felt that the landscape or the culture of certain units changed with how many of our veteran nurses left and how many new grads and travelers we had. But I don't know in terms of what our hospital systems are doing about that. I'm not sure the answer.
Yeah, and Cody, that's a good point. One thing worth highlighting is just a reminder to us that we had an escape valve and we got to leave these units for a certain period of time. And our nursing colleagues were there day in and day out and did not really have that similar respite that we did. So we have seen a lot more turnover. But I think to their credit, so many of them have stayed there and provided us with a way to catch up to speed every time that we came onto that unit. And so although it's been a difficult period in sense of turnover, the nurses played a huge integral part in our successes.
At the twilight of your career, when a trainee asks you what it was like to be a resident during the COVID pandemic, what will you say?
Truly, I will remember the first nights I spent in the CCA and being too afraid to walk too far away from the unit because I didn't know what would happen to patients. I'll remember how I don't think any of us really thought we knew what we were doing in the beginning, despite the fact that it was a disease process that's not too dissimilar from a disease process we've seen before. And there was so much uncertainty with what to do, how safe we all were, how safe our families were. I think those are the pieces I'll remember the most.
I think two things. I think it stands out how it felt very terrifying, but also like an honor to be able to participate, especially in the early stages of this pandemic, when it felt like every person that I knew outside of medicine was staying home, asking, what can I do to help? And we could walk into the hospital and actually do something to help. And it will also, I think I'll never forget how devastating it is to watch patients be critically ill alone.
Yeah, and just to round us out, I think the camaraderie and the selflessness from my co-residents to the nursing staff to the faculty is something that I'll remember for the rest of my career. And then the last thing is just how apparent health disparities were during this time and how difficult it was on those communities. I think it's something that hopefully will motivate a lot of us to try to implement some change, see if we can make a dent in that regard.
All right, I think it is just about 1 o'clock. I want to say again, thank you for this medical grand rounds. Thank you for this powerful talk, for giving a narrative voice to something that so many have felt and others have only watched from the outside. Yours is a unique perspective for all the trainees and of course for our chiefs. Thank you very much.